The most common causes of post-operative fever are summarized by the 5 W's mnemonic: wind, water, walking, wound, and wonder drugs, or what did we do? Wind is for atelectasis and pneumonia. Atelectasis occurs as soon as immediately post-op and can be seen on chest x-ray as reduced lung volume with increased opacity. It is important to pursue pulmonary hygiene aggressively to prevent and reverse atelectasis with incentive spirometry, ambulation, and/or chest physiotherapy as necessary. Pneumonia occurs on day 2 to 3 and is also diagnosed on chest x-ray. Again, pulmonary hygiene is an important form of prophylaxis and treatment. Additionally, hospital-acquired pneumonia is commonly treated with vancomycin and piptazo for MRSA and Pseudomonas coverage, as well as atypical organisms. Pain control is a double-edged sword in that opiates can cause a number of complications, including hypoventilation. On the other hand, inadequately controlling pain leads to splinting and essentially decreased full breaths, so an optimized pain regimen that ideally includes non-opiates is necessary. Additionally, post-op ileus can be precipitated by opiates and lack of ambulation. Abdominal distension can decrease the chest volume, leading to a temporary form of chest bellows disease. Thus, pulmonary hygiene, pain control, and ambulation as early and often as possible are essential for the prevention of pneumonia. Water is for UTI. This is usually about post-op day 3. A post-op patient, especially if they had a Foley, needs a UA with reflex to culture if they begin experiencing frequency, urgency, and/or dysuria. Bactrim is the most common treatment. Remove the Foley as early as possible. Use sterile technique when placing, and avoid placing the Foley if possible to prevent UTI. Walking is for DVT from not walking. This is usually about day 4 to 5. In addition to the other reasons that ambulation is critical, venous stasis from lying in bed and hypercoagulability from the release of tissue factor during surgery can precipitate clot formation. Anticoagulation is indicated, and use of SCDs are also important for prophylaxis. Classic signs would be leg pain in one extremity that is significantly, about 3 centimeters according to Wells criteria, larger than the opposite side. I won't discuss Wells criteria in detail, but you should be familiar with it. Hohmann's sign is said to be roughly 50% sensitive and 50% specific for DVT, but it will definitely show that you're paying attention if you test for Hohmann's sign. Diagnose with venous Doppler. D-dimer is only useful to rule out DVT. Many ill patients will have an elevated D-dimer. Patients with a DVT will almost certainly have an elevated D-dimer. So if the D-dimer is not elevated, it's very unlikely to be a DVT. Additionally, always remember that cough, shortness of breath, chest pain, and/or hemoptysis may indicate that your thrombus has already become a pulmonary embolism. You're diagnosed with a CT angio or VQ scan. To treat either DVT or PE, give heparin and bridge to warfarin using oxygen as necessary. If the patient is actively bleeding and anticoagulation is contraindicated, an IVC filter may temporarily be used to prevent migration of DVT. A PE should always be followed by an investigation for the source of clot. Wound is for wound infection. It'll take several days for this to develop sometimes, maybe even up to the end of the first week. The patient may even begin having fevers and chills. It'll likely be painful, warm, and erythematous with or without purulent drainage. Remember that some of these will be normal, minus the purulent drainage. Remember the ORs: color, rubor, tumor, dolor, Latin for heat, redness, swelling, and pain, the 4 signs of inflammation. Some are normal, but acute worsening is not. Get an ultrasound to ensure that there isn't an abscess. Treat cellulitis with antibiotics and abscess with incision and drainage. Culture the wound and debride as needed. Finally, wonder drugs and what did we do are for iatrogenic causes of fever, including drugs. Malignant hyperthermia is more of an intraoperative complication usually and is treated by dantrolene. Transfusion reactions, SSRIs, withdrawals from medications, gossipoboma, or leaving a sponge in the patient, opiates, and even inflammation from the surgical trauma itself are all causes of fever that are at least somewhat iatrogenic and should be considered. Thanks for watching. Please like, comment, share, subscribe, and hit the notification bell for more great videos. Remember, if you don't want to miss it, look below and click it. Check the description for more great study resources.